Okay, looks like everybody immediately outside the door is in the door. Excellent. Welcome, everyone. Thank you very much for joining us today at the regional meeting of the World Health Summit for this session on Trans-continental collaboration for global health. My name is Adnan Haider. I serve as the Vice Dean for Research and Innovation at the Milken Institute School of Public Health at George Washington University in Washington, D.C. And I'm really honored and privileged to moderate this session today. And I'm really excited that you've taken the time to be here. And I know there are some other exciting sessions going on as well. So thank you for being part of this session. I want to start, as I'm told is customary, by honoring the people who originally owned these lands. You know, in the United States of America, the same is true. We had indigenous people who owned the land at which my university, GW, the largest real estate next to the White House, is owned by my university, 16 blocks. And that was actually Indian territory. But we never acknowledged them. And I think it's an excellent tradition here in Australia. And of course, I wish you will go beyond acknowledgement to actual empowerment. But I'm very excited at today's session. I do want to warn you, though, it's going to be challenging. It may make some of us a little uncomfortable because we're going to get into topics and I'm going to stimulate the panel a little bit. So this is for mature audiences only in terms of intellectual discussion. We will get into intellectual depths, I hope, and conceptual depths, I hope, as well. But we will make it exciting, and I want to make sure that all of you are involved and engaged in this discussion. Ladies and gentlemen, the face of rising nationalism, rising tides of introvert thinking, and looking inside, this notion of collaborating with peoples outside your countries is incredibly important, especially for public health, especially for global health. If the COVID-19 pandemic has taught us that in fact, our health is dependent on the health of others as well. But what is this phenomena of transcontinental collaboration? Why do we care about communicating and collaborating with others across the continents? Why is it useful in terms of our technological basis? Why is it important in terms of our philosophical and ethical basis? Where have we done it well? Where can we improve? These are the types of questions that we hope to engage today, this morning, for the next 90 minutes or so. And I'm so happy and impressed at the panel that we have today. And of course, I want to thank Monash University and the M8 Alliance for wonderful collaboration in organizing this session. There are 5 of us on the stage here. Just to let you know that all 5 of us claim to be public health experts. All 5 of us have some sort of professorial title, adjunct or real. And three of us, I believe, are physicians or former physicians in some way, shape, or form, myself included. We actually represent 3 WHO regions: European region, the Pan American region, and the Wipro region. So we do represent some diversity, you know. We aren't exactly the same, and I hope that will come across in our statements as well. Each one of my colleagues is eminent, experienced, and has a bio that I can actually spend the next 90 minutes on, but I won't. And I have informed them of that as well. The way the session will run is I'll welcome them and ask them to spend 5 or 7 minutes with an opening comment about their thoughts on transcontinental collaborations for global health. When all 4 of them are done, I will pose a question or 2 so that they can reflect a little bit more, and then I want to open up for an engaging discussion with you all. Feel free to ask questions. I will give you guidance on how to ask a question when I come to that particular moment in time. Let me begin then with our first panelist, and I'm really honored to welcome Ambassador for Global Health and First Assistant Secretary of the Department of Foreign Affairs and Trade of the Australian Government, Dr. Lucas De Toca, who, as I said, is a physician, public health expert, and adjunct professor. Really welcome to have you and listen to your thoughts today. Thanks.
To be clear, I've always refused to use the fake academic title until the dean of ANU issued me an instruction to use it because it had been conferred. But yes, adjunct and honorary professorships are not real professorships. I acknowledge that. Academia also doesn't implement policies in the real world, so it's good to have the translation. Look, this is a hard panel, very difficult to start it off after that wonderful scene setting. I'm looking forward to the fruitful discussion, and I actually don't want to spend too much time in the opening because I think getting into the thick of it will be more interesting for us. But just a few ideas on how we see this setting. Things are getting harder. The world is getting more challenging, and unless we really look at how we can connect different regions, how we can work across maybe non-traditional alliance models, we're stuck because the problems are only getting more complex, the solutions are less apparent, and the world is more polarized. We are seeing a number of forces that are not new. A lot of the anti-science, anti-institutions movement that we are seeing now really started many, many years ago with tobacco and the 1950s tobacco science coming to its form. So then tobacco industry starting to undermine scientific authority and expert trust, which then was the same movement that the fossil fuel industry used for climate science denial, and then that leads to the current anti-vax movement and other conspiracy theories. All of that with some links to particular political and religious groups, often in rich countries. So in that context, we are seeing, given and what we thought were assumed democratic values under threat. I was talking to Anders before about whether the social democratic framework that we've been having since the end of the Second World War, particularly in Europe and in other so-called high-income countries, is maybe not working anymore, is maybe not able to meet the current challenges. And what we're seeing is that the same funding movements that allowed that anti-science or that harbored that anti-science approach are often linked to the ones that are also undermining democracy or some of the fundamental rights that we're seeing now challenged in the UN system. For us, there's sort of two examples that we're grappling with at the moment in our handling of these issues are the pandemic accord and how we come out of the COVID-19 pandemic with a stronger global health architecture. And the other one is the pushback on women's rights, the pushback on sexual rights, the pushback on the rights of LGBTIQA+ people and other minorities that we're seeing in every single space of the multilateral space. So the questions for us are some of the usual terms of health diplomacy, like-minded countries or in good company, the sort of standard alliances that the West, and again, the definition of the West seems to change wherever you are. If you're in Southern Europe, you think you're the West, but if you're in an Anglo country, they tell you that Southern Europe is not the West and the West is only the English-speaking world, even though I thought Western civilization was a Greco-Roman thing, but that doesn't count, I think. So all of those traditional definitions, whatever they were, might not work. And what we are seeing is, for instance, in the sexual and reproductive health and rights space, where, and I mentioned it yesterday, things like gender-responsive care are now almost a bad word that you need to pull out of resolutions if you want things to get passed. And we don't want to give up on fundamental issues. We will never give up on human rights. But there is also a question on where do we focus the effort? Where is language so sacrosanct that we can't give it up? And is it worth risking not passing things like a pandemic treaty? And I'm not saying we have the answer. There's a live conversation that we need to have within our societies to continue to define who we are. But it's a very present one and one that we grapple with every day. We're having discussions about priority populations, care for LGBTIQA+ people in forums like the UNAIDS board, where their mandate is to support priority populations. So what we are finding is that if we go to the traditional alliances, if we go to the traditional blocks of EU, Australia, Canada, New Zealand, etc., that only fuels our West versus the rest dynamic. And it's used by actors, often bad faith actors, like some of the countries that are less supportive of democracy, to say this is just an imposition of Western values. And unless we look at ourselves very carefully and really confront our responsibility in that dynamic and our responsibility in those narratives allowed to be put forward. And unless we are a bit smarter and try to work with others across the broad world and understand their worldview, so that we put together something that doesn't compromise on human rights, but doesn't sound like just Western ideological imposition, we're going to keep losing in the broad theatre that we're operating on. So we are seeing that countries that are not part of the traditional blocs that would move these things have proven to be the most effective allies in this. Thailand is very staunch in its defense of these rights in the international sphere. Mexico is a really active participant. Brazil now, very strong in our support, and things like rights of First Nations peoples. And we see that Australia, as I was saying yesterday, as a sort of northern but sort of southern, sort of western but sort of eastern country, has an opportunity to keep working in that space. But we can only do that if we keep platforming diverse voices, if we're just not a monolithic post-British hangover type of country as we were presenting ourselves in the past. So I think transcontinental collaboration, working across non-traditional groups, making sure that voices are heard, acknowledging the diversity that exists thanks to migration in high-income countries, and using that to our strength to be able to be more representative and reach across. It's not only something that we should do because it's right and it's human and humans exist in all the diversity, but I think it's the only way that we can preserve the rights that we take for granted. Thank you.
Thank you very much, Lucas, for that. And your reminder about both traditional and non-traditional blocs in the transcontinental spaces is indeed very, very exciting. I'm going to move on then to Professor Rebecca Ivers. Dr. Ivers, for those of you who have any relationship with non-communicable diseases and injuries, will already know her, is a world authority on injury prevention and research, head of school of the School of Population Health, right here in Australia at University of New South Wales, and of course, a public health expert. Rebecca, over to you for your deliberations.
Thanks, Adnan, and I'd like to acknowledge the Wurundjeri people of the Kulin Nation. I'm also here with one of my other hats on, which is chair of the Council of Academic Public Health Institutions Australasia, which is how I know Laura. We collaborate together in global networks of public health institutions. And I'm not going to make any snide comments about real or honorary, real or not real academic titles. On a serious note, actually, what these titles do is that they recognise alternative knowledge systems and expertise, and that's why people have them, and that's why they're so important, and that's why we do honour those titles, and we are very proud of the adjuncts and honorary academic titles that people hold, because it is a way for us, those embedded in university and institutions, to actually say, academic knowledge isn't everything. There are many other people with lived experience, with real life experience in policy and practice, and we value that knowledge. And we can't work without partnerships. And I think this is what this conversation is about, is how do we recognise alternate voices and knowledge systems? It seems like a week ago, but it was only yesterday when Ilona Kickbush talked about knowledge exchange, not capacity building, capacity development. What we're here for is knowledge exchange and valuing knowledges and lived experiences of others. And I think when we start thinking about transnational cooperation, that's actually what we're doing. And I'll talk from the perspective of public health and health workforce. For those of you who were here in this room yesterday, we had a session on workforce and shortages and how do we address that. It was incredible. It was a fantastic session, and thank you to everyone who contributed. What really came across in that is the need for the shortages in the skilled workforce globally in many regions. I think there was a beautiful paper that Rahina Joshi, who's here in the room and who spoke yesterday, wrote about the need for 43 additional health workers to attain targets for universal health coverage. And the most acute health workforce shortages are in sub-Saharan Africa, South Asia, North Africa, and the Middle East. Now, there are skilled health workers in the world. It's just that the West sucks them up. We have incredible brain drain. So, and Professor William May from Fiji National University all spoke yesterday, and really it's actually, I would say it was heartbreaking actually listening, because he said we are training doctors and we're training nurses and they just disappear, and we just have to keep training more and more and more to keep up with the workforce needs that we have here in Fiji, but also in the Pacific. And they're not all coming to Australia and New Zealand. Some are going to the private sector, some are going to other places, but there are many countries in the region. Australia and New Zealand, our workforce planning is based around other people's training. So we give aid on one hand to the Pacific, and then we take it right back tenfold over by taking all the health workers and other skilled workers that those countries then train. So it's something, and I think for Luca and for government, actually that's really important, that we now say Australia is actually, there is a WHO workforce policy that framework that we actually write, we're signatories to. But we certainly don't adhere to that. In terms of skilled migration, we are taking, we actually do have to start developing a conscience and saying, well, actually Australia needs to plan our health workforce. We actually need to start training people ourselves and not rely on other countries to actually around our health workforce planning. And that's something we do need to take very, very seriously. The other thing that I think, and this is where collaboration comes, is how do we work? How do we actually do this? How do we do the knowledge exchange? How do we do sharing of skills? There's a lot that high-income countries learn from the countries in the region. The knowledge exchange is real, but we need to actually work much harder on that transnational cooperation in the area of workforce planning and support and knowledge exchange, partnering with regional universities in public health. We know very little about what the public health workforce needs are globally. We know a lot about health professionals. We don't really know a lot about what we need in terms of epidemiologists, people working in health promotion, communication experts, and so on. That's something that we also need to do. What COVID really did teach all of us is that we work from our whole health system's actually structured in a Western biomedical framework. We don't value alternative knowledge systems very well. And COVID taught us very much that that's completely wrong, and that we will fail if we don't actually change the way in which we deliver healthcare. If we don't work with the community, and you will have heard from many of the First Nations colleagues and partners and friends here, that if we don't actually listen to local knowledge and local priorities and build on that, healthcare will not be delivered appropriately. We learnt that in COVID. In Australia, we saw that actually diverse communities in southwestern Sydney who were most, in New South Wales, who were, hard hit by COVID, nothing made a difference until the leaders of those communities were engaged. And then when they were engaged and then action could happen, then things turned around very, very quickly. We need to actually start, when we start thinking about what our models of care are, we actually have to throw things out and start thinking anew and actually listening to others and saying, what is it that we need to do and who do we need to do that with? So going forward, I think, in terms of, collaboration, around public health, it is about thinking what are the new models of care, thinking about we've got challenges to primary care all over the world, thinking about different ways of delivering care using community health workers, multidisciplinary teams, thinking about how do we do that. And that has got to be done across borders. We have to look at how we plan our workforce, but we also have to deliver about the way in which we deliver healthcare. I think I've spoken for too long already, but one of the examples of where we're actually doing that and actually looking at different models of care is, and again, it's in hip fracture care. We've got an epidemic of ageing. We've got ageing populations across Asia, and we don't have very well developed health workforces. So again, part of the new delivery of healthcare is going to be about multidisciplinary, team-based care, not necessarily medical-led care where you have a doctor at the apex of a pyramid and everyone follows. I've been working with colleagues, orthopaedic clinicians and nurses and others across Asia on co-designing new models of care that actually takes into account, that applies a different multidisciplinary model of care that might not include these fancy clinicians that we have in high-income settings, orthogeriatricians who are geriatricians that specialise in orthopaedic care. If you're in rural Nigeria or, rural India or China, you're lucky if you've actually got a surgeon, let alone a geriatrician, let alone an orthogeriatrician. So how do we actually make sure that we can deliver that there's everyone in the community, from high and low income within countries, actually has got access to quality care. Well, it comes back to new models of team-based care and new models that actually allow high quality care to be delivered in an equitable way. We need to start thinking about those kind of things as well and applying them locally led and owned, adapted to local circumstances, and not fly in, fly out specialist-based teams. So there's some of the things to think about going forward. So I think there's lots of opportunities for all of us to work together, but in many ways it is about a rethink. It is about knowledge exchange. It's about listening and learning and applying those knowledges equitably to make sure that everyone has got access to equitable health outcomes.
Thank you very much, Rebecca, and your examples on health workforce as well as on models of care is really, really important. And thank you for mentioning brain drain. As a Pakistani physician who migrated to the US 32 years ago, I'm a drained brain, and we'll come back to that particular element of transcontinental collaboration as well. I'm really honored now to introduce Dr. Anders Nordström, the advisor and former ambassador for global health of the government of Sweden. He has returned to the academy, is working now at the Karolinska Institute, but is also an activist, I am told. And I'm really excited because Anders, I learned yesterday, is also working on global health diplomacy. So Anders, over to you for your reflection.
Thank you very much. I thought you were going to make me a professor as well, but having listened to Rebecca, I understand I should definitely not go there because I'm a practitioner. I've been working on health issues, global health issues now for 35 years. I started in this region in Cambodia, working for the Red Cross in a hospital there. I'm going to talk a little bit about why transcontinental collaborations is important for global health. Both why it's important and what is the way forward. But before doing that, just a couple of words about what is the content of health today. Because again, if I look back, global health is still, and has been for many years, focusing on the old, what we called MDG agenda. Maternal health, child health, AIDS, TB and malaria, with all rights. And it's been important and we've made some huge progress. So when we started then at the beginning of, or even at the last century, 20 million people were dying from those three sort of goals, or related to those three goals. Today we're down to 8. So huge progress. At the same time, we have seen an increased number of people dying prematurely from NCDs. We have 18 million people dying today in the world. Is the global health community dealing with that? No. Those are people also losing their lives too early, before the age of 70. They shouldn't lose their lives. So we have a different agenda today, I would say, also for the global health community. We have an unfinished agenda, we have an agenda that we're still not dealing with, and we also have the agenda of now outbreaks of diseases and emergencies in terms of number of people being affected, number of people dying, not sort of compared to still the NCD burden of disease, but still an important agenda. Why am I saying this, and why is this important for the transcontinental collaboration, is that the old agenda, quote unquote, that we still are working on. Look, you came back from the Gavi board meeting. That was an agenda where high-income countries contributed resources and were supporting low-middle-income countries. The agenda I'm speaking about now for the future in terms of NCDs and outbreak of diseases is an agenda for all of us. And that's a big difference. And we have still an architecture today, the international system, that is focused on the old agenda, not the new agenda. We're beginning to see some changes when it comes to outbreak of diseases, like the pandemic treaty. NCDs, no. Why, again, is then transcontinental collaboration important for those two, sort of two new areas here? Of course, for the outbreak of diseases, it's a given that we need to share information, we need to have a surveillance and alarm system that works for everyone. We need to have ways of actually ensuring that we get the medical countermeasures when we need them, which we didn't do this time. So, I mean, there are a number of very practical reasons why we need to work across regions or globally. But for the other agenda, then, for NCDs, why is also then working across continents or region important? Mainly because of the risk factors. I think, Luke, as you were mentioning, the tobacco industry, of course, the alcohol industry. My main interest today is around food, energy, and urban development or urbanization. Those are also development that could go either in a positive or negative direction, depending also on multinational forces, food industry, but also if you take any, which is a bad example, which is moving us in the wrong direction. But if you look at what is happening on the energy side, from a climate perspective, we are making some progress, definitely. But we're not talking about the health benefits of that, which are huge, very important. And the same thing, what is happening in terms of demography, what is happening in terms of urban development, urban settings, more green areas, more opportunities for physical transportation in cities, also a trend that we see happening across the world today. Extremely important for people's health. And those trends to do with food systems transformation, energy system transformation, and urbanization or demography are trends that cuts across continents. And that's why collaboration in between continents are of extreme importance today. I'll finish just with my suggestions in terms of how we can move forward. And again, I was the Swedish ambassador for global health for 13 years. I have a background in WHO in different places. I'm not in academia. But from a practical point of view, I'm today speaking about advancing global health beyond three things. Advancing global health beyond the MDGs. Advancing global health to where are really the health needs of people. I'm coming from Sweden, and some of you know my former and now late friend and professor Hans Rosling and his bubbles. Hans always told me, know your figures, know your epidemiology, what is really affecting people's health. Both what people are dying from, but what also are the risk factors. So move beyond the MDGs, first one. The second one is move beyond the health sector. Move beyond health service. Again, we heard yesterday speaking about that is only possibly contributing to 10-15% of total health outcomes. But we are still, in our minds, thinking about healthcare as the solution. It's not. It's part of the solution, but it's definitely not the big solution. And the last one is around move beyond aid. Again, Luca, you came back from the Gavi board meeting. We are still thinking about that international development assistance is going to solve the global health issues. What I have said, what the global health issues are, and if we're going to take them serious, that those are issues for all countries across the world, then we're no longer talking about aid. Now we're talking about then investment in global common or global public goods, and we need to have a dialogue with our Minister of Finance that we need other money, like we have other money today to invest in financial stability in the world. Why don't we have other money also to invest in global health? Thank you.
Thank you very much, Anders. And those 3 pointers are really, really important, and I hope we can come back to that in our discussion. Really appreciate that. And then closing the first round, I'm really honored to invite Dr. Laura Magana, the president of the Global Network for Academic Public Health. And Dr. Magana is originally from Mexico, was an academic for many years, and is now leading this mega association of hundreds and hundreds of schools of public health. Thank you, Laura, for being here, and would love to have your comments.
Good morning. Thank you so much. It's really my honor, my privilege to be here today. And can I have my presentation? Thank you so much. And first of all, I honor the regional people from this land as well. And as well, all my colleagues, esteemed colleagues here in the panel that who already have set the tone of the discussion. But I'm really looking forward also to engage all of you in our discussion and conversation, because there's so much that we need to be learning from each other. And because we are all here, I'm assuming that I don't need to convince you the importance of transcontinental really collaboration and alliances. We all know what the importance of this. So I'm going really to do two things. First, in my opening remarks, I'm going to present to you one of the things that we're doing in academic public health. So now I'm representing academia, so I'm glad of this panel. It's really already a diverse panel. So from the academia perspective, what are we doing in order to really encourage these collaborations? But I'm more really looking forward for the second part when we're going to be discussing with all of you about the challenges and why we are not doing this in our schools and programs. And I'm really looking forward to hear all your comments about that. But let me start by saying, so let me just think here, no. Okay. So I'm representing today the Global Network of Academic Public Health, and this is a very recently new initiative. So I want you to think that all of our schools and programs of public health around the world, most of us belong to the regional association. So these are the 7 regional associations of schools and programs of public health that exist in the world. The only region that doesn't have actually a regional association of schools and programs is the Middle East. And we're working with them right now in terms of just, they really want to organize themselves in an association. But you can see here, and most of you, wherever you come from, must be represented, of course, Australia, which Rebecca is here. She's the CEO of that association, is here, and I'm so proud to just sharing the stage with her. But I'm actually the president of ASPPH, which is also there in America, although we have members from around the world, but mostly like 90% of our members are from United States. So this is a global network. So as Adnan was saying, we represent more than 450 institutions in more than 100 countries in 6 continents. And what's our goal? So our goal is really to enhance academic public health worldwide through mutual learning. And for us, this is a very important concept, to mutual learning and collaborations between academic public health institutions globally in order to improve and protect the health of people and the planet. So you can already see in our goal the 3 key principles of our association. It's a learning network. It's a learning really environment that we really stress. We really rely on collaborations among all of us, and we have one purpose, and that's to protect the public around the world and, of course, the planet. So we have priority areas, so I'm going to just show you and go to 3 very specific examples very quickly. But we work with workforce development. I'm going to show you one example of that. Of course, we embrace and we really promote public health education. Basically, right now, our priorities are climate change and health, and you understand why. Also, public health ethics, faculty development, and young professionals. And of course, we together advocate for investments in education. So just to give you a very brief examples of what we are doing right now, in terms of the young professionals, we have this initiative, which is called this Public Health Global Grants Initiatives, where this year we're running the second cohort. We have 20 different projects around the world where people submit, and these are students that work sometimes with their faculty in providing us with some of the examples, some of the projects that I want to do around the world. And this is our cohort. I don't know if you can read them, but you can see all the different topics. And no matter what topic, when we think about why we are doing this, so it doesn't matter that it's infectious disease, NCDs, climate change, conflict and wars, all of the global health issues really needs collaboration around the world. So you can see that all these people that are working right now in their projects, we meet often online, and we are sharing. This is a learning community, and we are sharing what they are doing. It's really an amazing way of starting just to get to know everyone and what they are doing. So that's just one of example. Another example, the number 2, and I'm going to share 3 examples. The second example is about climate change, which we all know that's one of our priorities around the world. So we partner right here with one big consortium also, which is the Global Consortium on Climate and Health Education. And with them, we do constant webinars, materials, tools. We put together a hub that all the faculty around the world can actually go for resources in order to teach their courses in climate change. And the last one that I want to present is the partnerships with WHO, which we partnered with them because 2-3 years ago, they started the WHO roadmap in order to prepare the workforce of the world towards the next pandemic. So it's a preparedness work. So we work with them for the last 2 or 3 years, and all the materials are ready. Actually, they're going to be published like in a couple of weeks. This is the first material that we published like a year ago. But right now, those are the 3 areas that we work. But the action area number 2 is a competency-based education. So once it's there, I'm will be happy to disseminate the link, because there are resources there for everyone around the world in order to just say, what do we need? What is our workforce need in terms of competencies? So you can develop your own curriculums in your own countries or institutions. So for all that work, we all know that we need partners. We need to really work collaboratively. So these are some examples of the different collaborations that we already have and we have established. So not only our network, but also our network has established collaborations with other networks in order to really advance academic public health. So I just wanted to start by those examples, but I'm so looking forward to talk about challenges. Thank you.
Thank you very much, Laura. And that's a great example to start with in terms of the transcontinental collaboration. Wow, you've got 100 plus countries and 450 institutions. That's amazing. Congratulations. So, ladies and gentlemen, you've seen the powerful opening statements by all four of our colleagues. So let me sort of tease out a little bit more and ask them to reflect maybe 2 or 3 minutes each, and you have some portable mics there next to you. On 2 points. One is, what do you perceive as the top 2 challenges in transcontinental collaborations for global health? And you can respond to that either by talking about a challenge or talking about an example where you feel that's not gone well. And maybe if you have time in that, to talk about a positive example as well. So an example of transcontinental collaboration, but really highlighting either a challenge or something that really helped make it successful. So I'll start with you, Lucas, and go that way. Again, 3-4 minutes each.
Definitely picking on me, always starting. So, okay, back to the pandemic accord. Pathogen access and benefits sharing. So for non-pandemic nerds, sharing a sequence or a pathogen sample and then using that to develop medical countermeasures against that pathogen. The expectation, consistent with other protocols like Nagoya, that if a country willingly cedes the pathogen of the sequence, then they should have access to the product that it's developed from it, which at the outset makes sense. Hard to operationalize because of you don't want to delay that access. One of the strengths of the COVID response was that the virus was sequenced and publicly available within days, and then that allowed rapid production of vaccines or therapeutics diagnostics really quickly. Some countries, understandably, South Africa, for instance, say, we have excellent genomic sequencing capability and surveillance. We detected Omicron really quickly. We shared it with the world, and then the world closed the borders to us for identifying that pathogen. So we need some guarantee that we won't be not just penalized, but we'll have access to whatever you produce that will help us control the pandemic. So I think conceptually we all agree. The trick with the accord is how to do that in a way that doesn't delay the development of the diagnostics or MCMs that we want to build. So that doesn't require establishing agreements every time there's a new pathogen detected and shared. That's been a lot of the crux of the delay in reaching consensus in the accord. I think we're getting there. But so one of the things that have been discussed in the text that was published last week is a system by which countries and companies sign into this PABS, Pathogen Access and Benefit Sharing system. It's almost like a pre-existing COVAX, so that we don't have to invent it every time there's a new pandemic. And part of that would be setting aside some of the products that the companies would produce and setting aside some of the purchases that the countries would put in so that they can be used for this global stockpile, either sold at cost or for free, and there's a percentage there that then can be accessed in case there's an issue. One of the most useful framings that I've seen on this to cut some of this divide that Mike Ryan, the Deputy DG of WHO, came up with, is we get really stuck in the sort of north-south thinking that probably a low and middle income country will identify the pathogen, they will share the sequence, and then pharmaceutical companies and governments in rich countries will develop their therapeutics, so then they'll set aside some of it so that poor countries can get it. Sure, that's sort of what happened on this one, but what if the next one, the pathogen is identified and then the therapeutic, the diagnostic, the vaccine is developed in China or in India, not in the US or Europe? Then it all flips now. And now that 20% set aside is actually for the US or for Australia to have access to it. So I think we need to be careful and not always think that it's always going to be the same and that we are just putting 20% for charity for the poor countries. We might be the ones needing to use it in the next pandemic.
Great, thank you. That's a great example, the PABs. And I really liked what you said at the end, the flipping of the paradigm, because the expectations will flip. And maybe we'll raise that again later on in the discussion. Rebecca.
Thanks, Adnan. And I'm going to think a global example. As Adnan said, I work in injury prevention, largely road traffic injury. And, for many of you in the room, you think about public health and global health, you probably don't think about car crashes really as being a global health issue. Well, it is. It's one of the leading causes of death and disability for people of working age globally. So some of the cornerstone measures of prevention of road traffic crashes is safe vehicles. It's only one of them. And, just on an aside, when we start thinking about climate change, what we should all be doing is thinking about how we can actually drive less and get out of cars. So I'll just leave that thought with you. Make sure you're on your bike on the way home or on the train. But one of the really big issues when we start thinking about collaboration globally around road safety is about vehicle standards. We know very much, and so in high income countries we've got very well developed standards about what a safe vehicle actually looks like. And because it's regulated in Australia, for example, we've got Australian design standards which any new car in the country sold has to adhere to, which are basically basic safety standards. But that's not the case globally. And the automotive industry globally really exploits that. So even within Australia, you can still get cars that have got limited safety features, a lot of working vehicles, which obviously people of working class are more likely to drive, have got lower safety standards. So they might have as fewer safety standards as the BMW or the Volvo that someone who's got more money might buy. When you actually start looking at globally, though, and the way in which the automotive industry, and again, we need to just think about it as a commercial determinant, is actually, you think about safety, and that's absolutely exploited. And that's something where we need national, global regulation and cooperation. And it's got to be legislated. There's voluntary codes. But of course, when you come to commercial interests, voluntary codes aren't really worth much money. So in India now, the government of India is actually, because they've got a really vibrant local automotive industry and a lot of lobbying, the safety standards for new vehicles in India are absolutely getting better. Likewise in China, we import a lot of cars from China into Australia, but are the cars that are manufactured in China that exported to Africa, do they have the same safety standards as the one that come to Australia? No, they don't. Africa is really pretty much a territory where, a continent where vehicle safety standards are incredibly variable. And again, it comes back to commercial determinants and commercial interests, where you're going to make a quick buck and where you can get away with it, in the same way that tobacco companies were basically selling cigarettes to young people in Indonesia because they could, because there was no regulation. We now have a framework that might stop that. But again, we need to start thinking about that. We know for public health, it's not just about healthcare, it's about, and road safety is very much a public health issue. So when we start looking at these kind of frameworks, we need to start to think about, well, how do we actually work with companies? How do we work with commercial interests? How do we regulate that? I mean, if you've got any great ideas about how you regulate the automotive industry globally, bring them forward. But that's actually one of the biggest challenges to public health globally, is how do we work with industry partners? How do we regulate it? Because voluntary codes, ethics, I mean, you can just throw them out. They're pretty much non-existent. We actually need regulation, and we need global frameworks and regulation around these kind of areas. So that's an example. I don't really have the answer to it, but I think it's something that we need to think really deeply about, because for many of you sitting in the room, you might not be thinking about road safety as a health issue. Well, it absolutely is. And these, and that's why WHO, we have a UN road safety collaboration that Ad and I have both been part of for many years. We think about it globally, but again, it's just trying to get it into everyone's consciousness to start thinking about that as a public health issue.
Thank you very much, Rebecca. And that really also adds to the outside health thinking that Anders just told us, that we need to get outside the health service sector. And this is well outside that, so great example. Anders, over to you.
No, I think it's a great example also how global movements really can make an impact. And I think the road safety movement is one good example. The tobacco is another one, even if we are not there at all. But still, we have seen a huge impact if we look back. Let me reflect a little bit in terms of why, what are the challenges and where can we make some progress? If I look back, HIV/AIDS in the 90s, we got enormous commitment and engagement from people across the world. I have the privilege of being the interim executive director, starting the Global Fund in the year 2002. It was enormous support at that time, and solidarity. But it was solidarity then in between North and South. And this was mainly, even if we had also cases of HIV/AIDS in the North, but still not at all as many as we had in the south. Then I had also again the privilege of being the head of the WHO country office in Sierra Leone during the Ebola outbreak. Again, enormous solidarity, and people were really concerned about we need to stop this. We had a great team of epidemiologists coming from this region, etc., and we then came to an end of that outbreak. What is different now then? Why aren't we then coming to a pandemic agreement now based on the COVID-19 experience that was much bigger? And I think that has to do with a little bit what I was talking about before, that now it's certainly about all of us. It's about all countries across the world. And certainly then the nationalism comes in here. I care about my people first. And the sort of case for multilateralism today is much weaker because of how we came out of the COVID-19, unfortunately and strangely enough, but I think it is. I think we've seen stronger regions now coming out, which I think is a positive thing, that we can collaborate within the region. But still, I think the nationalism now is really sort of influencing the possibilities of what we can do, because this is now not just affecting a country in Africa, it's affecting Australia and New Zealand, and we are part of the same sort of situation now. And the second one is, as everybody has been saying here, are the commercial sort of interests here. And I think that's the major issue why we are not coming to an agreement on the pandemic treaty in Geneva. It's about money. This is not even to do with politics, it's about the commercial interest behind here. And that, I think, is also influencing. And my big sort of interest today is food, and that's the most difficult one because there's such a huge commercial interest in that.
Thanks, Anders. And again, both your points are extremely important. I think we need to delve deeper into when we think about others versus when we are not part of the problem versus when we are part of the issue and it can affect us, and how that framing changes. Very insightful point. Laura.
Thank you, Adnan. So from the academic perspective, I think that one of the biggest challenges is how do we transition from a silo-like profession to a collaborative profession? And what I'm thinking is that if you think about not only public health, but if you think about health professions at the overall, we train our health professions in silos. So this is the public health track or school, and this is the School of Medicine, this is the School of Nurses, this is the school, blah, blah, blah. Then we have 10 different, if not more, 20 more health professionals, each of them independently trained. But then we expect them to work together, right? So that's the same thing that happens globally. So we are in the training, we never have a case studies international, we're very local in terms of what we're teaching, the faculty, and then we expect them to be global thinkers, try to collaborate, to do alliance. But in order to do that, that's a great thing to do, it's like, where do we start? Because that starts with a mindset. We need to be thinking globally in order to act locally. But where do we start that in our educational system? So I think that this is a systemic problem because this is a higher education problem system. So I think that we need to start thinking about what are the ways that we can do, and then the things that we need to really transform our educational systems in order to start the competency and to embed the competency in our curriculums. It has to be there. It has to be accountable. The accreditors, they need to say, like, how do your students really act, collaboration globally? We need to demonstrate that competency. So where is it in our curriculum, and what are the ways that we can all do, because there are ways to do it, in order to really start thinking about more globally. So I think that I want to end, just my point is that we always expect things to happen, but we don't invest in those things to happen. We need to train the people to do that. We need the competency very early on. And this is very related also to the other competencies that right now we're seeing as a very important competencies in our students, which we talk about resiliency, we talk about humility, we talk about empathy. So how do you expect to demonstrate that if you don't have exercises or examples or your living conditions where the others are also important? So we need to realize that really all of us work into a common goods and to work for the others and for the good of the benefit of the planet. It really requires intention. It's not just a good thing to do. It's an intention, and it's education. We need to learn. We need to be training to do that.
Excellent point, Laura. I mean, this is really important. You're saying that expecting things to change without investing in future leaders is tough. We'll come back at some point to our practitioners and say, can you teach people how to collaborate, or is it experiential learning? We'll come back to that question, but I think your thesis is that you can do something in schools and in the education system. So folks, we've heard a lot from our 4 eminent panelists, but it's time to engage with you and see and hear about your ideas. First, by the way, there are many chairs here, and we are very friendly folks in the front. So if you want to make a transition and secure a spot on these chairs, here's how the next section is going to run. I'm going to take 3 or 4 questions or comments, and then request each one of my panelists to reflect on them for a minute or 2. You have 1 minute to ask a question or a comment, because you're not a panelist, right? So think about your idea. Think about your idea. Crystallize it in a 1-minute question, and then let it come out. And we'll hear your question. But if you're here to make a statement, I'm actually going to cut you off after a minute, okay? So who's going to be, by the way, that's called the Hyder rule for moderation. So our first question will come from, yes, sir.
Testing, yeah, right, 1 minute going now. Tony Blakely, University of Melbourne, Public Health Medicine Specialist Epidemiologist, also currently Chair of the New Zealand Royal Commission of Inquiry on COVID-19. My question is for Lucas and Anders, I think, but it's a generic one. When I was an expert commentator on the pandemic, I got furious at people who would say, and we must have equity in vaccine distribution, and the very next sentence they would say, but our country's too slow, we must get more. And here we are in Australasia where things were going very well. I'm now seeing it from a different perspective since I've been appointed as chair as a Royal Commission behind closed doors, so I've got to be careful what I say here, whereby people are saying, oh yes, it's lovely, pandemic accord, but frankly we don't trust that. So we really need to ensure that we're at the front of the queue next time, and we didn't get the front of the queue well. I find that ethically very challenging because I'm supposed to represent New Zealand here, but I also have a stronger global health ethic here. There are 4 options that I can see this playing out. 1, the pandemic accord works and all the world coordinates. 2, countries move to multilateralism in their region and work out pandemic vaccine agreements. 3, we leave the vaccine companies to do the allocation because nobody else will. 4, it's the Hunger Games and it's just all on. I'll be very curious as to what your comments are about that.
Thank you very much, sir. Put your hands up, please. I want to see them up and wide, so I want to distribute the questions a little bit here. Yes, the young lady right up front, yeah.
Thank you so much. And my name is Rashri Thapa and Monash University. So my questions is in line with the Honorable Speaker Andrea. So we talk so much about the containment of the NCDs and COVID-19. I think one of the major reasons why we could contain COVID-19 or communicable disease was also access to medications and the vaccines. But I think one of the very critical issues and the very large inequity we see at the moment is the gap in terms of treatment access for NCDs in HMIC and LMICs. I think that's one of the major global agenda for trans-continental collaborations if we want to improve equity and have access to NCD drugs in LMICs, because this is not only issue of LMICs, but also to HICs. So although communicable disease and COVID-19, there was a very fast response because we thought that that would come to the HICs. But what I would like to stress is that if we do not invest in non-communicable disease access to medication now with the migrations, I think that will be a global agenda. Thank you so much.
Thank you very much. I thought I saw a hand back there. If not, the gentleman right here.
Thank you very much. I'm Irtakian from Tehran University, Iran. Thank you for a wonderful chair and wonderful panelists. We learned from Ilona Kekpush yesterday that the lack of trust is one of the main risk factors. And Michael Marmot this morning said to us that the Thai experience, which is based on the 3 triangles, on academy, people, and the government. This is about transcontinental collaboration. So what is happening in the world, putting another side, is nationalism. As you said, it is widening. People come to the ladder of power who are supporting nationalism rather than collaboration. Mm-hmm. And we have been serving the people who are losing trust in us as healthcare professionals and as the government. So my question is, Ben goes back to the public health entity, which is about collaboration and working with people. And given this context, that the willingness of people for collaboration is coming down, how we can actually, as the health community, as a global health community, can do something ourselves, you as a global health ambassador, for instance, to convince the politicians and work with the people in these three capacities in order to bring them together, because otherwise we talk about our wishes, but on the other hand, the things on the ground are changing in another way. So my question to all of you, how we can tackle that. Thanks.
And the last question for this round, keep your ideas up. I'll take one more question and then I'll do a second round. Yes.
Thank you. My question is to the panel around, I guess there's no comment around the impact of political and economic sanctions. So the double, I guess, jeopardy is third world countries are imposed sanctions for any breach of any kind of human rights or any misconduct, but first world countries are not subject to the same level of accountability. And looking at the impact of COVID, Pfizer has done trials in African countries that has led to lack of trust around vaccines. And then in the pandemic, that was a vaccine that was touted the best vaccine. So looking at that kind of no conversation around the fact that political and economic sanctions are the reason for brain drain and a lot of the problems that we're talking about. How can our countries trust transcontinental collaboration on health, yet health actors don't speak on those, the impact of those?
Thank you. Thank you, ma'am. So, panelists, we've got 4 questions. You can pick and choose whichever one or address all of them in 2 or 3 minutes each, starting with Laura first.
Thank you so much. Well, I was thinking about very challenging questions, but I'm going to pick in the one about trust. So you were thinking about, like, what do we do now? And again, I'm putting here my academic hat. And I was thinking about what's our role in academia in order to really elevate the trust that we have really, that public health has lost during the last years. And I think that, remember, in the schools, we do training, we do research, we do advocate, and we work with the practice community. So I think that we need to tackle through all of the 4 areas of our mission. So we need to keep on believing that it's through education. I'm sorry, I'm a great believer in education, and I think that through education is the way we really can really elaborate, evolve in our minds, in the minds of the new graduates, in order to know, like, what's the right thing to do. So I think that to keep on training them in this, but also research is such an important thing. We need to keep on advancing the research, not just for the journals, and I know that all of us are maybe measured to the extent of our journals that we publish, but it's much about how can we translate that knowledge to our communities and to our politicians in order to understand what we are saying or what we are finding in our research. So we need to keep on doing that. And the practice one, we are the ones who actually work a lot with our communities and with the practice partners. So we should keep on doing the right thing to do in public health with our communities that we serve. And lately, the advocacy, because I think that we all need to keep on advocating at the local, at the regional, and at the global level in the right approaches to what we are doing. And again, I want to pick again about the silos, because I think that the more we do this through our interprofessional education among our health professions and then beyond our health professions, the better we are in trying to regain the trust. That's going to be a hard journey. That's not an easy thing to do. It's very easy to lose trust. It's very hard to build the trust again, but it's about the actions that we're doing that we need to keep, again, being accountable to the public and also always, being truth to the findings that we're doing in public health.
Yeah, no, thank you very much, Laura. And I think this exchange is really important because it demonstrates not one cycle of lack of trust, but decades, and in some cases, centuries of lack of trust. Every time the powers were trusted, they actually did not provide benefit, but rather the opposite. And I think that inculcates a sense of fear and cycle of mistrust. And your point is very well taken. Anders.
No, thank you. Just a couple of more practical aspects of trust. My own personal experience is don't give up, continue. We can't give up, even if it looks a bit challenging. The second one is trust has to do with delivering. If you're delivering, people will trust you. And then getting the attention to health. When I've been working as an ambassador, but never a politician, but I work with politicians, is to make health attractive. And that's, again, with the same thing, hard work and ensuring that you can deliver. Then you will also get your politicians to actually to be interested in it. Question then about New Zealand. I would go for a combination of option 2 and 3. basically saying that I believe that regional platforms are the future. We need also then to have the regional resources, and we need to have regional ways of actually then negotiating then with the industry to get the right kind of deals, the right kind of agreements. And I think that needs to be done now. And if you're going to have public investments in the R&D to get new vaccines next time, you need also to get public benefits from those investments. And I think that's part of the solution, the way forward. I don't believe in any longer in global solutions for this, but doing it at the regional level and doing it upfront and doing it as part of negotiating then with the industry in terms of who is going to benefit from this. But recognizing that nationalism is difficult. In Sweden, I was with the Swedish Prime Minister when this began. He wrote an article together with the New Zealand Prime Minister at that time, together with another 7 Prime Ministers, saying that we absolutely need to go for global solidarity. Did we do that in Sweden? No. We vaccinated 100%. For the European Union, we procured or we went into agreements for 5 times as much vaccines as we needed. So there are lessons to be learned. Finally, just on the NCDs and low and middle income countries, to be a bit provocative here, I think there are resources in those countries that are not used well enough. I worked, as I said, in Sierra Leone during the Ebola outbreak. Sierra Leone being one of the poorest countries in the world, we think. It's not. They have enormous resources from diamonds and minerals. Are they going into the public system or the official system, the government system? No, they are not. Governments have a responsibility also in low and middle income countries when it comes to good governance and taking care of the resources that are there. And I think we need to begin to speak about that a little bit more than what we're doing today. So there are, I think also the epidemiological sort of trends is that the NCDs is basically now happening. The trends is clear. All middle-income countries have now the majority of the burden coming from NCDs, meaning that you are also spending your health expenditures on those diseases. That is happening just naturally. But then to get the spending up, if I look at high-income countries spend about 9-10% of GDP on health, low-income countries are spending 5-6%, major because of a big informal economy. But there are ways of actually bringing some of those resources into the formal economy that I think we need to speak about more.
And Anders, that last point is really important because unless people themselves invest in their futures, the dependency on others to solve their problem will never go away. And LMICs have to demonstrate that investment. They do so in defense, by the way. It's very clear, the investments in the defense sector in many, many cases, and that often is the comparator. Rebecca, over to you.
Look, it's a great point. I want to come back again to the concept of trust, but also the rise of nationalism. And we're seeing that globally, but I think we really need to start thinking about where that comes from, and it is not devoid of politics. And global health is about politics as well. So I think we need to be really mindful about that and understand those relationships. Nationalism often rises from people who have no voice and power. So partly it is about politicians responding to people in the community who've got no power, and it's actually about politicians exploiting that. And we see that over and over again with the far right. It is about exploiting fear, people who fear of otherness, being exploited. And again, that's something that we do need to create a lot of pushback for. But I think it does also comes back to then where I started, which is actually recognition of people's knowledges and experiences and partnership and trust, and actually giving them voice and power. We know that voice and power, being able to control the things around you, actually leads to better outcomes. It leads to better health amenity. It leads to better communities. And that's what we need to come back to, some of those fundamental principles that we know are so important. The other thing, moving on from that, I think, is coming back to the concept of NCDs, but also silos globally. We're talking about global health, we're talking about pandemic treaties, we're talking about vaccines, we're talking about and tobacco treaties. But we're talking about them in silos again. We have these frameworks, but we've got to remember that health doesn't exist in isolation. When we talk about NCDs, we might talk about medication, but actually that's after the horse has bolted. Actually, we want to start talking about prevention of NCDs. And when we talk about that in terms of global collaboration, we need to be thinking about how we organise our cities, how our food's organised, what are food policies, how do we get around, what's our transport option, how do we move, how do we reduce the burden of NCDs by changing the way in which we live, and how do we work together to do that? So I would actually challenge everyone in global health to start thinking, we do need to think big picture. So we want transnational, global cooperation, but we actually have to think outside of our silos as well. We do need to think about our cities, our countries. We need to think about our politics. So just a challenge to all of us to actually stop thinking about our disciplinary areas and to actually start thinking about how do we work together. And of course, I'm a public health person, so I'm going to say public health is in everything, but that's what we need to think about. You do need to think about how we apply that.
Great point, Rebecca. And not only that, but I think you're bringing in the multi-sectorial effort for health outcomes. This is not just for other outcomes, but simply for health outcomes. And the other thing maybe you were alluding to is the fact that low and middle income countries don't have to follow the pathway of development that high income countries of today may have necessarily followed. And therefore they can create their own futures in a very, very different way. Lucas, over to you for your reflections on these questions.
Thank you. And yeah, they can create their own futures as long as we continue the dialogue and make sure the multilateral development banks and the IMF support that. On nationalism and trust, I think vaccine nationalism was a very real thing, and I don't think it's going away anywhere. I think it's very live in the pandemic treaty discussions. And Australia had a similar experience to New Zealand. I was in the national COVID vaccine program before moving to foreign affairs, and we saw that very clearly. We were slammed by the public for starting later compared to other rich countries. And yes, we achieved, I think the Australian Capital Territory with Canberra was vaccinated 111%. And then we had millions and millions of doses ready to expire. Indonesia was able to take a lot of them, because at peak they were vaccinating something like 2 million people a day. So they were very happy to take short expiry vaccines. And yes, we were the biggest provider of vaccines to the Pacific. But I think we can all agree that the distribution of vaccines was haphazard and not ideal. I also think that there's a bit of a read as well that it was because the time was so warped during that period, and years feel like days, but also days felt like months because everyone was locked down, etc. The reality is that for the majority of low and middle income countries, access to vaccines was within 60 days of what happened in high income countries. So there was a delay, there was maldistribution, absolutely. I'm not shortening that, but I think we may have remembered it as much longer than it was. I think we all agree that didn't work. And what's probably in our favour, and hopefully will help us get there somewhere with the pandemic treaty, is that it didn't work for the companies either. They were constantly having to amend contracts to then allow donations. They were catching up on orders that they couldn't fulfill and warehouses that they couldn't actually move because countries weren't ready to accept, because there was such demand that couldn't be met at the beginning and then oversupply in the second phase. So actually the industry bodies that we have been negotiating with as part of the pandemic accord have been more forthcoming with reform than we expected, because it is in their interest to have a system that allows everyone to buy in before the things happen, that guarantees the supply, that reduces the risk in the R&D because they know they're going to have buyers. So that's the framing that we're trying to achieve, so that we can end up in a position in which, yes, we address the nationalistic concerns because they're not going to go away, but also can align, hopefully, those commercial determinants to something that is useful. And for countries like ours or New Zealand, yes, we're rich, but we're also like 3 people and in the middle of nowhere. So we have no leverage in terms of early access. So it is in our nationalistic interest to get a good deal for the globe.
Yeah, great point. And I think you've raised a very important point, which is when things align, and you've given an excellent example of COVID, where the industry's interest and the political interests and the health interests are all aligning, and it seems that this will lead to completion. But what if when they don't, right? And the food and the living spaces that Rebecca is talking about, and is when your interests don't align with industry, then how do we get global collaboration? When the alcohol industry says we want people to drink more and therefore, but they have to drive, and they ignore that part, then what do we do? And those are the difficult choices that we have to make. Let me first get an idea. Do people have questions? Oh, there are people. Okay, can I have my volunteer microphones here? Can I take the gentleman in the back? Yes. And everybody remembers the short question, 1 minute rule. And let me do another round of 3 or 4 questions. Yes, sir.
Michael Bartos, I'm a global health writer. I think the question partly is global health a global public good? And that would mean it would have to be non-rivalrous and non-excludable. Now, you talk to Pfizer, and of course, being rivalrous and excludable is how they make billions of windfall profits out of a vaccine. Although let's also remember that, you know, more people were vaccinated with Sputnik and Sinovac vaccines across the world than with Pfizer or Moderna products. So, and Oxford AstraZeneca was another model again. But just thinking about and bringing it to the nationalism question. I mean, one of the questions is whether and the big divide. Lucas, you would try to sort of say, well, you know, what are the new alignments going to be? The big divide, it seems to me, is going to be between those who want race-based exclusion models, and you know, it's white supremacists. It goes a lot to the question of India's elections now. It goes to the question of what Israel is doing now. So exclusion versus cosmopolitanism is the word I like. Because in cities, we learn to manage these things. We share these things. That's what cosmopolitanism is about. So yes, just to ask the panel whether they think that might find some basis for sharing.
Good question. You've used some very powerful words. I'll see how the panelists react to that. Yes, the young lady right here. Right here, right here. Oh, I'm so sorry, I didn't see you. We'll get you next. Yeah.
Okay, thank you very much. Emma Rule, United Nations University's International Institute for Global Health. It seems to me that you can't talk about collaboration without talking about power. And you can't talk about trust without considering power. And that's true whether it's at the level of individuals, organisations, or the multilateral system. But talking about power asymmetries and shifting power makes many people deeply uncomfortable, especially if you've got power to lose. And so my question to you is, can you share experiences, positive examples, or hope for where power and power asymmetries are being positively talked about and affected? Because if we don't, it seems to me that we will only ever have sticking plaster solutions to what are deeply entrenched systemic issues. Thank you.
Great question. Great question. Thank you, sir, and sorry to miss you first time.
Yeah, thank you. I'm also a joint PhD student at London School of Hygiene and Tropical Medicine in UK with Nagasaki University in Japan, and also I'm assigned the note taker for this session, so trying to make a good question and write a good reflection, submit to the meeting. So I was hoping to ask for the corruption issues from those those countries who need the help in this trans-continental collaboration for global health, because ultimately, in a plain language, they are just poor. So, and the poor is connected to the corruption issue. And there are basically 2 kinds of the direct corruption and the indirect. And the direct is like they're gonna quote for very expensive stuff from Germany, but they actually purchase the very cheap stuff in those China and India. Those kind of the direction and corruption. Also the indirect is the collaborator, because the government or the local collaborators, not just the ordinary people, they are poor, but the government are really poor, and also the local partnership, they might be poor as well. So they may do the indirect, the corruption that they propose very fancy intervention, for example, those digital technology, but actually doesn't quite work really well in those low and middle income setting. But yeah, it's just the project that can make them make huge benefit. And also there's a fundamental issues laying that, which is the trust, as you rightly mentioned, because kind of the trust in those countries are built on corruption. Only if they can get the good money, then they will trust the people from the high-income countries for collaboration. So I was hoping to ask, how do you think about the corruption issues in this transcontinental corruption?
Yes. Thank you, and there was somebody right at the back signaling to me, and yes. And if you can have a quick question, because we'll go around to get some reflections.
Tejaswini, Social Work, Monash University. And my question really, thinking about all the speakers over the last 2 days or so, is the pandemic experience and how evidence needs narrative. Democracy does not always have the outcomes we have. So what I'm asking to the panel is to reflect on some form of value-based leadership, the role of courage in actually advocacy, particularly advocating for people who are vulnerable, etc.
Thank you. This round is really amazing. We are covering everything from global public health good and racism to power to corruption to courage. I will let you 2 minutes to each of you, and you can reflect on any of the above. And this time I'm going to go this way and start with you, Lucas.
Right. Look, I don't want to turn this into an advertorial of Australian new international development policy, but one thing that I touched on yesterday on the morning session, and if you're going to read any piece of Australian policy, it's the first chapter of our new international development policy, because what it does is acknowledge the power asymmetry in a way, in a subtle way, because it's still uncomfortable and we're a predominantly Anglo country, but it centers who we are, and it doesn't say we're just neutral. You know, the classic white position of we are just objective and separate, and everyone brings their biases to the table, but we are the white male is the neutral observer. Now this chapter defines who we are as Australians, their connection to the globe, the First Nations perspectives, and it falls short of completely acknowledging those power dynamics, but it does acknowledge that when we engage in the Pacific and when we engage in Southeast Asia, we do it with a history and a shared history with some of our partner countries that it's not always and quite often has its darkness. So I think it is starting to recognise what we bring to the table, and it helps us in our engagement to acknowledge that power dynamic. But I completely agree. I think we can't pretend to go into these collaborative spaces. We can't pretend to go into multilateral meetings or Gavi Global Fund board meetings and not recognise that the dynamics between donor countries and implementing countries, or whatever euphemism we use for that, are complicated. In terms of where this works a little bit better, I can think in a domestic example when we're responding to COVID. I mean, one thing that has been probably the biggest inequality issue in Australia is First Nations health, and probably the biggest gap in terms of our non-Indigenous and non-Indigenous population in health outcomes and others is here. For the COVID response, it's probably one of the first times that government formally acknowledged and ceded some of that power differential, establishing a shared decision-making system for First Nations communities to actually guide how the COVID response is going to work in those populations. From the get-go, it was established at the very beginning of March 2020, and every single step that it was taken in that in the response to COVID as it pertained to Indigenous communities was actually truly a shared decision-making process between government and communities, which then turned into, as opposed to the usual, which is somewhere in government designs what we do and then maybe tests and consults at the margin and implements. It was actually this group of community leaders that decided how to use the tools of the state to respond to it. So things like biosecurity legislation to restrict access to remote communities at the community's request, or even deploying the army for assisting with the vaccination project. It was so successful that for the first 2 years, rates of COVID in Indigenous communities were 6 times lower than in general population, as opposed to what happens with Indigenous populations everywhere else. But it was so bizarre in the sense that community leadership was exercising the tools of the state that Amnesty International at one stage condemned Australia for the use of the military to impose vaccinations on Indigenous people, and they had to retract it when Indigenous leadership told them to go away and shove it, because this was actually at the request of communities. But it was so bizarre that it was perceived as an imposition.
Yeah. Great point, great example. Thank you. Rebecca?
Look, there's been some really challenging questions that have come up, and thank you to talk about that. But one of the things that I think we need to talk about is the need to speak truth to power. And that's important in global health, actually, and again, it comes back to education and really nuanced understanding globally, and it's got to be taught globally around colonisation and how health imbalances around the world have actually, how how we've got to where we are. And it does come from colonisation. It does come from, high-income countries sucking up a lot of resources and protecting themselves and actually not being partners and not authentically working for the good of the global community. And that obviously still goes on, and we know that. We've heard so much about that. I don't have the answers to that. But I think one of the first steps is that we do acknowledge that, and we acknowledge the need to speak truth to power wherever possible and actually articulate that and understand that. And our politicians need to understand that, our diplomats need to understand that, and we constantly need to, but we need to talk about it to the community. We need to engage the media around that, because we're not going to address that from the perspective of a high-income country unless we actually start having those really honest conversations. And I think, and completely acknowledging what happened during COVID for Aboriginal and Torres Strait Islander people in the country and the leadership role and the acknowledgement of that. But we have also just been through a referendum where the majority of Australians said no to an Indigenous voice to Parliament. It's been absolutely galling, horrifying, absolutely a slap, a pushback of people, the community, saying no, we don't want to shift the power imbalance. We don't want to hear your voice. And that's actually been, there's been, and I think for all the good, and there are some incremental changes in Australia about how the government and the community acknowledges and works, and the prioritisation of the importance of the First Nations people in Australia and the critical role that they play and always should play as the first peoples of Australia. But I think, again, we can talk about global health and talk about Australia's role in the region, but we have got there's so much work to do in Australia about speaking truth to power, about partnership, about acknowledging Indigenous leadership, about handing over money and power and giving that up. And there are changes, and I think for many Australians that work in public health and global health, people know about reciprocity and partnership, but actually how many of us actually truly give up power is another question. And I think we all do need to challenge themselves, both for Australians but also in the global, in the global setting. And I think it's that reflexivity that we need to work on. So that's not really an answer, but I think it's something. But we need to be honest with ourselves. We do need to practice reflexivity and actually think about what our values really are, and are we practicing them ourselves?
No, thank you for reminding us, Rebecca. Thank you. Anders.
I think the sort of key or tool to shifting powers is about win-wins. Where can we find situation where we actually have something mutual to win from shifting powers? And if I take a very concrete example from my own country, is gender equality, what has happened in between men and women in Sweden during the last 60, 70 years. That has been a win-win situation. It's been giving up power, you can say, but it's also been winning quite a lot. The story is that 1950s, we needed more workforce in Sweden to be able to grow our economy. The people on the economic side, they needed more workforce. The workforce were the women. We had a social democratic government at that time, and they said, fine, but only on one condition, that we also invest now in social security, healthcare, childcare, pension system, education, which we have a very good system even today. And that was a win-win situation because the economy grew. But even more important, I would say today, in terms of the values in between men and women, and between hopefully boys and girls as well. Me as a man, I appreciate this. I appreciate that I have had the possibility to be at home with my children, that I have the equal right to my children as my wife has. And that has been something to gain for me as a man. And I think that's part of the solution, how you shift powers, that you need also to look for those win-win situations. It's not easy, but I think that's part of how one should do that. And that goes also a little bit to the value-based leadership here. You need to have leaders that stands for certain values. And I think that goes both for leaders at the top, but also leaders in communities, among peers, among your friends, that you have leaders that have certain values that they are honest with and they are prepared to stand by for. I think in some countries, and I think New Zealand has been an example of that, another island close to me is Iceland, where they go for what they call a well-being economy, not just saying that economic growth is the most important one, but the well-being of people. My last comment just on, I'm not sure I 100% understood the question about corruption, but I think it's an interesting dimension about corruption, which is disease in quite a few countries, and in all countries across the world. But of course, in poor countries, it becomes more severe when the resources are scarce. We have corruption in Sweden as well, but it doesn't really affect you as an individual in the same way. That corruption in some ways is about trust as well, because it's in between trust in families, trust in different communities, and corruption is a way of also ensuring that you keep that trust in some way, which is difficult because you need to break that and you need to get a different kind of trust. And for me, that is democracy. I mean, you need to have democracy, you need to hold politicians and the institution accountable and ensuring that we move away from corruption, which is basic crime, stealing the money from the people.
Excellent point. And I thank you for picking up the corruption and poverty linkage. I think that was very important to clarify, Anders. Laura.
Yeah, thank you. Thank you so much for these incredible questions and reflections, because we are all learning. Doesn't mean that we all have the answers yet, but we are trying very hard to really advance. So thank you for your questions. And I was thinking about the impact of really the power and the power shift that we all are in desperate need of really seeing and finding ways to do it. I'm trying again to find an example in higher education. So the more I think about the shift in power that we need, I'm thinking about really we need a structural, we need to tackle the structural barriers that we have in everything that we do in every single area of our lives in an everyday basis. So we think about in higher education, what are the barriers there? What are the structural barriers that we need to tackle in order to really shift the power? And just an example, if we think about the students, for example, in the United States, in order to enter the universities or the graduate programs, you have to pass the GRE, right? So the GRE, he found out a few years ago that, first of all, there's nothing to do with GRE and success in higher education or in your graduate school, but it constitutes a great barrier if you don't have really the resources, or you have not been having all the resources previously to your education in order to make you being able to even, perform well in that. So, for example, eliminating, which, by the way, some of our schools are already eliminating the GRE as an entry exam, is one of the things, just one very small thing, but this one thing, as an example, that there was a barrier. There was a really structural barrier in order to allow more people to enter higher education. And there's something that there's hope, because there are things that you can do. Another example is that we're always trying to see, like, how can we attract, the students to higher education. I think what we're really not doing well, once you attract them, and we're doing some strategies in order to attract them, when they are in our education, then we're failing of giving them the opportunity to succeed while they are studying. Meaning that if we are really meant to shift the power of only the wealthy or only the well-educated people that goes to higher education, but we want everyone to really be access to those education, then we need to provide the services at the university level in order to support all these students. And I'm talking about maybe even starting with daycare centers for the mothers that have their kids there, and any other like mentoring programs, any other things that some of the students need in order to succeed. So our focus will be in succeeding education, not only the entry level, which most of our universities unfortunately are focusing, but actually focusing in the other spectrum, that if you want to succeed, if we want all students to succeed, and then even helping even identify like good jobs and mentoring for even longer time, that will be a structural change in higher education in order to at least start with that.
Thank you so much, Laura, and I think that's a great example for us to start with. So, colleagues, we started with a relatively placid discussion and have ended up with covering major concepts in global health and social discourse. I think we've made the case, I believe, that transcontinental collaboration is important for global health. It'll work faster if interests align. If there's a complexity, then if you can find a win-win situation, that will allow you to use power dynamics and power tools to make it happen. But the thought that I want you to leave the room with as you go down for lunch is to think about those situations where there is no win-win, but one party has to lose, because that happens in global health. And even a more complex situation where you need one party to lose because they have to be disempowered, because that power structure has to be changed, or because a systemic inequality has to be redefined. Under those circumstances, the interventions are not very pleasant. They sometimes have to be more powerful, and sometimes that is the actual reason why transcontinental collaborations are needed, because you need solidarity, the word that Anders, you very appropriately from Scandinavia talked about. And that, I think, is the solidarity towards which we are hoping as a social mission, as an eventual discourse for global health. Please join me in thanking our wonderful panelists today. And also, I do want to thank the wonderful questions and comments that all of you contributed. Thank you very much, and let's keep the discussions continuing. Thank you.